This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to jerrypal.org/CME.
And on to the show. Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, today we're going to be talking about the use of video to enhance advanced care planning. Who do we have with us today?
We have two repeat guests today, Eric. We have Kei Ouchi, who is an emergency medicine and internal medicine doctor and researcher who practices at the Brigham and Women's Hospital in Boston. Kei, welcome back to the Jerry Pal Podcast. It's been a minute.
Thank you so much for having me.
I love the energy.
And we have Josh Lakin, who's a palliative care doc and researcher who did his palliative care fellowship and residency here at UCSF. He's now at the Dana-Farber Cancer Institute, also in Boston. Josh, welcome back to the Jerry Pal Podcast.
Good to see you, gentlemen.
So we're going to be talking about two papers that came out that included some type of video-enhanced advanced care planning. One published in Journal of General Internal Medicine, JGIM, and another in JAMA Network Open. We'll have links to both of them in our show notes. But before we do, we always start off with a song request. Who has a song request?
Josh.
I do.
Josh.
I can.
What song?
It's the only one I could find that fit this one. It's called Video Killed the Radio Star.
Video?
Which I love, by the Buggles.
And we have done this one a while ago, but it's been a while. And I think I tried to change it up a little bit. Why did you choose this song, Josh? Is it just obvious?
Because we're talking videos. That's all I had. Plus, anytime you can bring the 80s into a conversation, you should probably do that.
And we'll see if you truly believe that video killed something, like an old way of advanced care planning conversations. We'll find out. All right. Here's a little bit. I heard you on my wireless back in 52. Lying awake intent on tuning into you. If I was young, it didn't stop you coming through. They took the credit for your second symphony, rewritten by machines on new technology. And now I understand the problems that you see. I met your children. What did you tell them? Video killed the radio star. Video killed the radio star. Pictures came and broke your heart.
That was awesome.
That was a fun one. This is a blast from the past. So one-hit wonder band. What was it called?
Yes.
Buggles or something?
The Buggles.
The Buggles.
Yeah,
That's a good trivia question. Who sang that song? Everyone knows the song. I doubt that many people know the name of the band.
Maybe for a little bit after this podcast, I'll remember.
Okay, so we got a lot to talk about. I'm going to turn to both of you first. Just why are you personally or got interested in this topic of improving advanced care planning through things like video? Josh, I'm going to turn to you first.
Yeah, so I've spent most of my career, both in training and then afterwards, really thinking about clinician interventions for improving communication. And there was something about considering ways of empowering patients outside of clinicians through these video decision aids that interested me. And I hadn't thought a lot about, we spend most of our time thinking about the words we're going to say and how we talk to people, how we are going to use different professionals to do different aspects of care. But the idea of empowering people with images and videos in their own languages that have been interpreted into so many different languages was interesting to me. So it just felt like a very different tool. And throughout my career, I've been lucky enough to just get to play with a bunch of tools for advanced care planning and serious illness communication. And this one was just unique in such a way that it was interesting. And Angelo Volandes, who built these along with his wife and the company ACP Decisions, are just so thoughtful about the way they deploy them. It was just an interesting new way of getting at what matters most to patients. And so that's how I got into it.
It's been a while since we've had Angelo on. We had him on.
I think that's probably the last time we sang the song Video Killed the Radio Star. After his book came out. And his company, again, ACP Decisions.
And we'll have a link to that podcast as well. Okay, Kei, how about you? How'd you get interested in this? You're in the emergency room, right?
Right. So as you can imagine, I clinically work as an emergency physician, and I meet a lot of older patients who has actually never had these conversations before. And this is just one study among my body of work of trying to figure out how can we leverage the emergency department to improve serious illness communication, right? And all my other studies, we use a clinician to actually kind of get this going, do motivational interviewing or something like that, with couple that with serious illness conversations. And when Angelo told me about this study and idea, I just thought like, how can we make this more scalable, you know? And video is just one way of making things a little more scalable. And now that we combine both of our studies, it combines the video, which is like totally reproducible, high intervention fidelity, with a very shortened human driven conversation after that. And I think that really attracted me to try to execute this study because I'm always looking for scalability. I know what is good. I'm just looking to see what we can reproduce.
Because you're studying, so let's talk about your study. It's called the Effective Emergency Department Initiative Video Enhanced Advanced Care Planning on Documentation and Goal-Concordant Care Randomized Controlled Trial, published this year in JGIM. We'll have a link to it in our show notes. It sounds like, again, you wanted to tackle something in the emergency room, right?
Yes.
Yeah, why is the emergency room a good place for advanced care planning
we're gonna
conversations?
start there? Okay.
Yeah.
Yes, I can
Like,
explain
why the emergency department? That's like, as you pointed out in the intro, like, there's not much done there, but that's probably because most people think it's not the place for it. Why do you think that's
Yes,
right?
I know that.
In and out
most
medicine,
of my-
right?
Right.
Yes, most of my mentors and friends think that that's not the right place to do everything in emergency department. And at the same time, this idea about intervening in emergency department actually came from Alex's paper when I was in training that showed, most older patients visit the emergency department in the last 6 months of life. And also, a lot of people have never had these serious illness conversations before. I still remember this, and those numbers are still true because I see this in clinical care. 1/3 probably of my patients are older adults with serious life-limiting illness. When I talk to them about non-acute care stuff, they have no idea. They're like, what do you mean I have this like really serious life-limiting illness? And I know that I can make this better by doing just a little bit emergency department to kind of kickstart this for these people. So I mean, this is all based on Alex's paper as well as my clinical experience. The emergency department only sees patients that you guys miss. All the outpatient providers miss. And those are the most vulnerable patients that we can actually move the needle on.
So let's talk about the most vulnerable. Who did you study all emergency room patients, or did you just pick a specific population that were most vulnerable?
We chose to study older adults with serious life-limiting illness. You can define that however way you want to define it, but we use it based on literature review. And then also include people without serious illness if they're older than, I think, 70. I can't remember exactly what the number was, but I think 70 years of age. And 70 or 80, I can't remember.
That's okay.
It's in the paper.
Just older, yeah. We'll have a link to it on our paper, in our show notes.
Yes. And we catch them in the emergency department while they're receiving their care, or if they're boarding an emergency department waiting for the beds to open up.
Yeah. And then you randomize those two people to just usual care in the emergency room. Is that right?
Yes.
Versus what?
Versus the intervention. So the intervention is, I think, a long time ago when Angelo Valentis first started with the video, it was just the video. And then now it's kind of combined with just very short components of serious illness conversation guide, like asking about patients' preferences as well as patients' hopes and values. That's kind of tagged along after watching the video. And then patients are kind of a lot of people get admitted. Most people get admitted, actually. And they just kind of go on with their care. And our team, the research team, will summarize. This is before large language model. So we actually manually summarize what was discussed in the video as well as what the patients had shared and message that out to inpatient and outpatient teams.
So there's kind of like three parts. In the first part, they view the video, and it is there any way our listeners could view these videos, or are they like firewalled off at ACP decisions?
Oh, I thought the patient-facing videos are all open.
They're all open? Okay, great.
I think so. I think I think the patient ones I thought were open, and if you were to use it in a health system or something like that, that is kind of blocked off.
We'll have a link to it,
Right,
listeners.
if it's available.
But and the videos, they could choose multiple different videos, right?
Well, actually,
or is there only one video
for this study?
For this study, it was just one video, and that video focused on what? Advanced care planning?
Yes.
Okay. And it was short. It was like 5 minutes, right?
Yes.
Do you need a video for advanced care planning? I mean, I know that's the topic of today's podcast, but I understood, like, I remember when we had Angelo on, he was like, when you have a patient who's really sick and, would consider being in the ICU if he got sicker and they're on the floor. I remember he wheeled the patient over to the ICU, and it was like, that was transformative. And he realized, wow, if they could only see it, I can show it to them. Like, what do you show them in that advanced care planning video? Like, do you show them a person talking with a surrogate and assigning a surrogate? Or do you show them like CPR or intensive care unit? Like what? Because the question is, like what goes into that video? Because you could imagine it might persuade people or bias people. Could be, some people might use those words in one way or another. Nudge would be another word, depending on what video you showed them.
Yes. So the video showed basically there's a narrator physician who is just kind of explaining about the process of advanced care planning as well as different interventions, and divide the care largely into 3 buckets: full care, limited care, and comfort care. Comfort care meaning like just comfort only, and limited care meaning you can choose however way, whatever you limit is kind of up to you, but it doesn't actually define what you limit, like intubation or something like that. And full care is full care, everything. And basically define the care into those 3 buckets. And then also explains about CPR and intubation. And it does try to educate the viewers in understanding what the probabilities that they're facing with each of those interventions, not in a specific number, but in general sense, like most of the time when you do CPR, it does not work type of situation. And then the viewers after the video are asked to choose, like before and after the video, what do you think about all these different types of care, and what would you choose is one question that follows the video. And then we go into talking about some values like hopes and stuff like that.
Okay, so you get the 5-minute video, and then you have this structured kind of ACP conversation based on, at least with clinicians who are trained on Vital Talk, right?
Yes. So how is that done is that Angelo did most of it, but I do the coaching afterwards. So we train the clinicians on like a route
What
map.
kind of clinicians? Physicians, RNs?
Yes. There was no physicians. And there were some social workers and RNs and medical students. And we trained them in the same way as just Vital Talk Remap, using the same type of actor-based training. Then it's not very long. It's only like 3 hours long. Just like if you can think about like the Vital Talk training in one shot and Remap. But it's not Remap. It's basically responding to emotion and asking key value-based questions like what's important to you type of situation.
So they get the clinician intervention, generally with a social worker, a nurse, or a med student. That one, the interaction with the patient lasts usually how long? Do you have a sense?
5-minute video and probably like 5 to 7 minute conversation.
And then
the person just writes them all down and then put it in red cap and summarize later.
And that gets sent out through the EHR, but not in the patient's notes, but through like messaging?
Not in the patient's notes. Yes.
Why'd you choose not in the patient's notes?
Well, so to do something differently is probably my answer. But so I have another randomized trial, very similar, but without the video, and using the human interventionist. And I document them in a medical record because it's, I would think that it's the
wherever you
best thing
look.
to do.
Yeah.
And it kind of complicates my analysis because I have to like de-identify those notes to kind of blind the outcome assessment. It kind of complicates my outcome assessment. It can be done, but it's kind of complicates it. And the inpatient clinicians are receiving the same message anyways.
Yeah.
So that's just try something different.
Okay, so they get randomized to these two groups, and then the outcomes that you look at. The first one is, did advanced care planning happen? How did you know if advanced care planning happened?
Based on documentation. So whenever there's a new, not documentation after the ED visit, and well, I used to do this in like a chart review type of situation, but this one is done by NLP by Charlotte Linval. And
natural language processing. So like,
yes, so it's more like so you can do high number of volume as well as more accurate reporting of it. So that's one outcome. That was the main outcome. And the increase in that, because, you would think that if there's a new documentation of some clinician discussing with the patient, it's probably likely that there has been some type of conversation that occurred. And we're not talking about like full code presume type of documentation, like actual clinician notes.
Yeah.
So that's sort of the assumption under why this was determined to be an outcome.
Mm-hmm. And the outcome, just to be clear, is not the clinician who had the conversation in the emergency department writing a note. That doesn't count. That's not what happened. They did not write a note. In
this trial, they did not write a note, so there is no such thing.
Yeah.
Yes.
So it was another clinician who wrote a note that counted as an advanced care planning conversation as determined by a natural language processing algorithm, basically like a computer program algorithm that combed through the electronic record and identified this is advanced care planning conversation. And we had Charlotta Linval previously on Jerry Pell to talk about this sort of stuff.
Yes.
Great. Okay, so that was that was the primary outcome. What else did you look at?
And we also looked at the patient's knowledge in ACP, which Angelo likes to do all the time. And then also the ACP engagement survey, Rebecca Sador's ACP engagement survey. And then finally, goal-concordant care.
Goal-concordant care? Holy smokes, Alex.
Oh.
We've had a lot of podcasts about this, and if I remember, you're always...
The holy grail of
Why is it the holy
care
grail?
research. Because it's so hard to measure, right? Did the treatments... I mean, that's part of the idea behind palliative care, right? This is what Diane Meyer said when some senator asked her, like, what is palliative care? It's aligning treatment with patients' goals, like at its essence, right? But then it turns out that measuring that is really difficult. How did you measure it?
So we decided that we will have two physicians who are blinded to intervention or control receive medical record number and patient's name of all the people who are enrolled and died. So these are all decedents, and go through the chart and try to decide on 0 to 1 scale, 0 being like totally discordant, and then 10 being perfectly concordant, like where this patient belongs based on like my own chart review, basically. So I'm going to do a chart review before they died, and we're going to try to figure out like, is there anything that was discussed about this patient about either their code status or their values and goals or whatever it is. Like we do like a manual chart review. And then we look at the care near death, or whatever that is documented at the time of death. And basically, if the patient said, I would never want to die in ICU, or, I would, most important thing for me is to be at home at the end of life or whatever. And if the patient died in ICU, that would be considered not concordant.
What if they changed their mind? Like
Yes.
in the emergency
So that
room, they didn't want to
happens.
die in the ICU, but like 3 days later in the hospital, they did. And then they end up dying in the ICU.
Yes. So as much as we can, we try to, starting from like 6 months before death to like the time of death, as much as we can, we try to check these time points and see if anything felt like it was different. And then right at the time of the last hospitalization and when they died, we try to come up with like, is it concordant or discordant?
So it wasn't based on the conversation in the emergency department. No. It could have been based on the ACP conversation that happened after that on the floor or in the ICU, for example.
Because these are all people who are enrolled. So like, our intervention conversation already happened, but that's never documented in the EHR. And then there are more documentations of the intervention patients in EHR after the intervention date. And then we follow them until they die. Well, not everyone, but, these are the patients who died. Like 90, some people died during the follow-up period.
Yeah.
And,
so it's a subset. It's not the full study population.
It's not a full. Yes.
Is this the Holy Grail, Alex, that you've been looking for?
Well, I do like this measure. I mean, it's limited in that it's only in patients who died. And of course, we want to follow people's goals, whether or not they die, right?
And you got to document everything.
And some people who get goal-concordant care end up surviving, right? They might get full care, all sorts of treatment like ICU care and such. And I really appreciated that in your figure, like the number 10, like the strongest agreement example was a patient who said they wanted to be full code and receive all care possible, all interventions possible, and then they ended up dying in the ICU after a prolonged stay.
Exactly. So it could be highly intensive care dying in the ICU as 10, and person who wants to die at home, dying home hospice for a long time, like, weeks, and then die at home, that's a 10 too. So 10 is best, and patients can choose what that means.
Yeah. Okay. So results. Let's quickly talk about the results. For the results, at 3 months, I think was your primary outcome, right? And you showed a significant increase in the intervention patients. 46% had advanced care planning documentation versus 31% in the control group. So big difference there. Any difference in goal concurrent care?
Yes. So that's the whole point. And this is probably the most exciting trial that I have done in my career until this point. Because of this secondary outcome, the primary outcome, I have shown the same thing about the same magnitude in my prior trials already.
I think Angelo has shown the same thing too. Like,
Right.
Videos improve advanced care planning.
Right. If you focus on advanced care planning, you will have more documentation
of advanced care
planning. Like that's okay.
Does it change anything?
Right. So what?
Did it change anything? You said yes.
Well,
what did it change?
Sounds like it really looked like when I was reviewing these charts that it did change something. And that's why I was so excited about it. But we didn't really know because we were blinded.
Yeah.
We didn't know who was in intervention or control. But when the blinding came off, it was kind of exciting. I felt like this is doing something.
Was it a big change, little change? Hard to quantify because it's on these 10-point scales.
Yes, so it's hard to quantify, sure. But I guess the difference was 10 versus 7 is what we found. And is that big? Is that clinically significant? Is what people always ask, right?
Yeah.
Is that clinically significant? And I mean, please imagine 10 is like the best possible, right?
You are concordant.
Amazing.
You have great concordance at 10.
Amazing.
And 0 is like, oh my God.
Totally discordant.
Like you guys aren't even, okay.
And so, is it clinically important change? Well, I'm certain that this is in the right direction for sure. And if it's hard to say what that 3-point difference means, but sorry, I can't remember what the difference was actually, but that point difference is a lot by like 3 or 4 points, I think. And I think that's really important and really meaningful to patients.
All right.
I suppose it also comes based on how that happened, right? Like if you took 2 people from 0 to 10 and everyone else was a 7, that seems like a win to me, right? Like if you dramatically change 20% of the population's experience, is that not a huge win? I don't know. I guess if you take everyone from a 7 to an 8, that's debatable. But if you take just a couple people out of 10 from a very low number to a very high number, and that's where your 3 points come from, that's avoiding what we would call never event kind of stuff in palliative care, isn't it?
I think that's just like a pharmaceutical trial, right? Like we're looking at these.
Somebody should get paid then, right?
Well, I think this is the challenge. Okay,
Yeah,
I'm going to ask you
I
this
agree.
before we go to Josh's article, is that like how outside of a research study, outside of a large academic institution, like is this practical to do? It feels like, because you're all about scale, right? It feels like the ACP video is easy. Shooting somebody a message is easy, but the hard piece is you get that additional step of having a clinician, spend 5 to 10 minutes asking these additional questions.
In the emergency room where you're so pressed for time. Yeah.
Yeah.
So I think, I'm sure you guys can all feel it and believe it. The world will change in like 10 years because of AI and large language model. And I really think that it's going to be scalable. Our next grant is already in, but something's more scalable. It sounds more scalable in that study. And because video is reproducible, that's one component. It can be incorporated into just a regular emergency department procedures that doesn't include me, the physician or nurses. And then the piece about conversation can also be done by palliative care trained AI speaker. And I'll come up with that later, but we're doing that too. And then the documentation and summary can be done by the large language model. And in essence, the really difficult part of this whole process is the final recommendation, right?
Yeah.
And then confirming all the values and goals. The physicians or clinicians can do that. The rest of like information gathering and preparing the patients and understanding what's going on, that can be scalable automatically.
So Vital Talk trained AI will have that conversation.
I mean,
that
they can also do the video too.
Yes.
It could be an AI-based video personalized for...
personalized. Right,
for that
right.
person.
So instead of giving them a generic, this is what happens to people who are seriously ill on average, you could give people like you.
Yeah. So somebody
These
with
are the
COPD.
outcomes. Right. Yeah.
With these medical problems, coming into the emergency department.
Mm-hmm.
This will have to be the third time we sing Video Killed a Radio Star, but it will be about technology advancing to AI.
Right. Yeah, killing off the poor med student jobs of doing these conversations.
Yeah, and video
I actually really think that all these technologies and all these videos and AI speakers and all that stuff and large language model will allow us, the clinicians, to focus on the parts that only we can do, make us more humane in that respect, I think.
Yeah.
Maybe. I think we'll learn some surprising things along the way. There's already backlash against AI. I wouldn't be surprised if these patients are like, no, I'm not. I'm in the emergency department. I'm not talking to your AI.
I don't.
I'll show you that next time.
Okay, you look forward to that.
I wouldn't trust United Health AI to tell me what to do.
That's right.
All right, Josh, let's go to your article. Intervention to increase advanced care planning among older adults with advanced cancer, randomized controlled trial, published in JAMA Network Open, amongst great authors. But I want to know from you, like, why, you told us a little bit about why you did this study. Like, what was the really interesting part of this for you?
For me, to be honest, was one of the questions you're already getting at, which is the pragmatic nature of it. I'd never done any pragmatic study before or a stepped wedge trial. And I was pretty curious to see if there would be any impact, clinically meaningful or not, by just kind of tinkering with the system without much control, right? So it was a randomized controlled trial, but it was randomized in a stepped wedge kind of way. And so
What's
you went in and...
step wedge. Is that type of shoe?
Step wedge.
Cheese?
Yeah,
I
it
think
sounds
it's a
like
shoe.
A shoe? Okay.
we can make it a clog, a cheese shoe, or something. It means that you randomize clinics over a time period. So these oncology clinics would get an intervention, which was the Vital Talk training, similar to what Kei described, 3 hours of communication skills around responding to emotion and talking about goals of care, delivered by James Tulsky and the Vital Talk team. And then they'd get teaching about the deployment of the decision aids, and then they were on their own. The researchers were not there to make them do it. They did not randomize patients within those clinics. They just had to run the intervention with some guidance from the research team. So that's way more real world.
And the intervention is, hey, these are some videos. And your article was a collection of videos, right? You can choose
exactly.
feeding tubes or goals of care or advanced care planning, hospice. You got this collection of videos.
Yep.
And then providers who may or may not have been trained, but they had the option to train around communication skills, Vital Talk.
That's right. And then they were left to the real world. And then the computer went in and assessed documentation. We can get to that later. But yeah, so that's what I thought was interesting, because my hypothesis was that won't change anything, right? Like without someone there telling them to do anything or nudging them along or pointing out, hey, there's an older patient over there, you should give them a video. Nothing would happen, right? So that's why I was interested. I was kind of curious to see how this played out in a more, it's not real world completely, but it's way more real world than anything I've ever done, where you're like really up in the business of the people who are doing the research, right? Like, here's a randomized patient, please go do this now.
And so why not why stepped wedge? Because that introduces time bias, right? Especially you guys did your study during COVID. Like, is it just changes with time that you're seeing, or is it like if you randomize individual providers, you can actually see, is there a difference, not pre-post, but with this intervention with particular providers?
Yeah. So in retrospect, especially since COVID happened to happen, that made it a very difficult kind of trial design to run. I don't actually know why Angelo and the team made that decision early on in the research. I came onto the team afterwards from an implementation standpoint. Yeah. But I think it has to do with feasibility of being able to get this intervention out to a lot of places, 3 different large health systems with many, many different oncology clinics. So it was to get the intervention into as many places as possible. But it definitely introduces that timeline bias, Eric, which is a huge problem, especially during COVID, no doubt about it.
And especially from a pragmatic trial, like actually you guys used 3 different large groups. There were tons of patients.
Thousands.
Yeah.
Step wedge was the cutting edge science at the time. It was like
that too.
It was you can't really randomize the patients because they're located within clinics, and you'd like to have all the clinics have the opportunity to participate in the intervention eventually. So you start by training some clinics but not others, and then over time, as you move along the wedge, you end up training all the clinics. And then for any individual clinic, you can compare it to other clinics that didn't have, let's say they have the intervention at the time you're comparing it to other clinics that didn't have the intervention at that time. And you can compare it historically to a time at which they didn't have the intervention previously. So there are advantages of step wedge. It's now somewhat fallen out of favor for a variety of reasons, including that it's very power hungry. And like if something happens temporally that shifts things in that time period, then it's kind of becomes, there's that before after element that's, a weaker design.
And importantly, pragmatic study. So you didn't actually look like, did the providers actually didn't have to do the training, or the patients didn't have to use the video? Do you know if they did?
There's data on that. I don't think Angelo has published any of the secondary outcomes. The data usage the video usage was quite high at 2 of the organizations and lower at 1 of them. But the video use was high, and the provider training uptake was pretty high too. So they put a fair amount of work into both of those things. So again, that from my standpoint as an implementer, I think those are 2 things that were probably higher than would happen in the real world setting. I think there was pressure to get that done.
Yeah.
So both were high. But it wasn't required, and the older patients weren't flagged, right? So it could be any patient watching the video.
Some difference between the sites, though. So 2 sites with higher use than another site.
Correct.
We don't know why yet.
No, we don't.
And did it do anything?
It did. So it changed. It changed documentation in the medical record as assessed by the tool that Charlotta designed. Again, that Kei described. Right. So there, I think it was a 25% to 20% roughly difference between intervention periods. Again, not clinics, as Alex was saying. So intervention time slots had more documentation than non-intervention time slots. And the documentation was assessed as natural language processing, looking for clinician documentation of goals of care kind of conversations, of treatment preferences, of hospice or palliative care. So it was looking for specific things. And again, that tool is a human assisted NLP, which I think Charlotta probably talked to you about. So there's a human coder going through the notes, but the NLP takes those tens of thousands of data points and distills them down to small quotes, chunks that the human reviewer can look at, who is blinded to whether the person is control or intervention time frame.
Mm. And is that, what do you make of that difference? 20% versus 25%. Like, it's not
A 5%.
it doesn't blow
difference
you
in
away.
advance.
It's also still pretty low. It's also like low at baseline. You'd think patients with advanced cancer, we'd be doing better at baseline. So there are a lot of stories there. What do you think?
Yeah, is the 5% worth the squeeze?
Yeah.
Good question. So I think as someone who's done implementation outside of research around palliative care and communication interventions, it's a bit impressive, actually, considering how big the institutions are. I don't think this number is an easy number to move amongst large institutions. So I'll say that I was impressed, right? I told you my hypothesis was this is not going to do anything. So I was a little surprised that even at an absolute increase of 5%, it was impressive, but a relative increase of 25% or whatever that is, my mathematics are not going to be good today. I was impressed.
You are starting to sound like a pharmaceutical company focused on the relative risk increase, but
Yeah, there you go.
not the absolute.
Yeah. But again, is it high enough? Oh man, I would have liked to see a lot higher. I personally would have liked to see a lot higher. And I think it begs the question of kind of which of these interventions and in what way are we going to get the biggest impact?
And it also sounds though like, is it the juice worth the squeeze? Like the lemon wasn't very big here, right? Like it was just access to videos and some training, but there was nobody saying you got to do this, got to do this. You're not hiring additional people.
That's right.
This was, as far as getting this up and running in someone's clinic, actually fairly low investment for a 5% absolute risk increase, which is actually quite large when you think about kind of what you're getting out of this.
I agree with that, Eric. Like, I think we've seen a number of studies that have shown that training alone don't move the needle. So here you had a combination of an elective training plus these videos, and we moved the needle a little bit, right? Which is something, I suppose. I don't think there's a magic bullet here that takes the number from 20% to 60%. I think it takes work. I think it takes a number of different interventions. And I think from a ACP study standpoint, this is a pretty low control, low push thing. And this is maybe what we can expect if you don't do a big push, right?
Kei, what did you think about the 5% difference?
I mean, you're talking about, so now we're only talking about our study of only like a few hundred people. These are like thousands of people, right? So in absolute number, even the 5% is a lot. And I don't know if my family member or myself was in that patient population, I would really like that. I think it's just the bigger scale.
Yeah.
The absolute number is really large.
One of the things I love about both of these studies is we've had people on talking about, prepare for your care, talking about Vital Talk, talking about video advanced care planning. And we're always like, how does this one intervention compared to the other? And what you did here is you married two of the interventions. It's the videos and it's the Vital Talk training, right? Like, so it's like Vital Talk in Kei's case was like used to train, the remap framework was used to train these clinicians. And in Josh's case, the clinicians had the opportunity to view these videos the Vital Talk, is it videos or interactive website, right?
Mm-hmm.
To learn the skills. So it was like a kind of a marriage of these two innovations. And that's, I think, one place the field needs to go. Is like often, we have these studies designed where there's just one intervention and you wonder, and it doesn't work so well, right? But now we're seeing these multi-component interventions that have these different parts, and it's, we're starting to see some positive results. And maybe that's what it takes, because we've had a lot of interviews with people who have conducted negative trials, right? Studies that just didn't work out for one reason or another. And one of the things I think is really interesting about this is that marriage of different interventions at the same time.
Okay, I got a question for both of you. And especially when it comes to this changing goal concurrent care, does this settle the argument whether or not advanced care planning works or not?
So, I mean, I know, I know you guys all know that there are many different ways to kind of measure goal concordant care. And
Yeah.
this is just one way of doing it. And when I saw this, I was like, wow, this is great. At the same time, a lot of people do question me, like, it's one way you do it and there are many other ways to do it. And also, do we actually care how they died? And don't we care more about how they feel before they die?
There's always
And,
something.
like, there are many different ways to kind of think about this issue. But I do think that we're getting to, it is a stronger outcome compared to, like, did the conversation happen?
Yeah.
I think.
Josh, there was no goal concurrent outcome in your paper, right?
Not in my paper. No, not in that paper. It's coming out. I mean, Eric and Alex, you'll see it. So there is a very cool study coming out. Michael Paciorlo, who's another one of the senior researchers on this, and Edith Burns at Northwell Health and Charlotta are using NLP and AI to try and do another step up on kind of what Kei described, where the AI tells the story of what it sees in the chart. The human tells the story of what they see in the chart. And then people decide if that's goal concordant, a description of a concordance picture using a scale again, which I have not been involved in that, but I'm super curious to see what that shows. So like, again, it's supposed to be more nuanced. Does this story tell a story that is one of a patient and clinician being empowered during a difficult time, right? Like, which I think is what goal concordance is about.
Okay, so my last question to both of you. You're a busy hospitalist CMO. You got the emergency room, you got oncology clinics, you got everything. You have a limited budget, but you've listened to this podcast. You've convinced them that something works, but they really only have the budget for one thing. Could be the videos. It could be a trained clinician in Vital Talk. Could be something else that we didn't talk about. Like, what would you tell that CMO that they should invest in?
I'll take that one first. Yeah, I want to take that one first. So I'm gonna double down on what Alex said, which is I'm gonna answer your question, Eric, but a little bit in a cagey way, which is I would get a list of the different tools that are out there. There's a good number of them that are free that include conversation guides, templates to fill out, workbooks for patients, patient videos, video declarations. Like, there's so many neat tools out there. I would give them a list of those. And then I would tell them to invest in their clinicians in terms of preparing them and giving them time to have these conversations and carrying patients through it. And then provide a list of tools that are out there. Because there's a lot of tools that people can use for free. And I do think the clinicians need some help, whether it's through training or through coaching and ways to create space to have these conversations and improve on it. So I put the money in the clinicians broadly, nurses, social workers, chaplains, everybody. And then give them the tools that we have all created, because there are a lot of cool ones out there.
Wonderful.
Is that fair?
I totally agree. I mean, there are many tools, and we already know which components actually work together to actually produce more conversations and more goal concordant care, I think. And the challenge for the health system administrators is to figure out how to make that more scalable, not just like, let's pay clinicians to do this, but how do we make this more scalable? And solutions exist. I think we have to invest in making this more scalable, like using AI and other things to kind of augment, like kind of reduce the time that clinician needs to spend.
Well, again, we're going to have both of you on podcasts for the next rendition of Video Kill the Radio Star. Talk about how AI has changed everything.
Yeah.
Probably like 6 months from now. But maybe we'll get a little bit
Tomorrow.
more of that song, Alex.
The pace is pretty rapid. All right, here's a little.
As you listen to the lyrics, just think about AI.
I met your children. What did you tell them? Video killed the radio star. Video killed the radio star. Pictures came and broke your heart.
I love that. One of the authors of this song, I just want to say a quote. When they came up with this song, they were picturing that a vision of a future where record companies would have computers in their basement and manufactured artists. So we are going to have that AI.
Yeah, there we go.
Josh, Kei, thanks for joining us on this podcast. Always
Such a pleasure to join. Thank you so much.
And thank you to our listeners for your continued support. We'd also like to do a big shout out to those who've donated more than $250 in the last year, including
Carrie Levy, Marnie Feltzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rock, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky and Yana Saraf, Kelly Strait, Michael Bordowski, Jessica McFarland, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, the John A. Hartford Foundation, Lloyd Woolstat, Harry Hahn, Bob Arnold, Ginger Robbins, Matt Schuster, Maureen Kearney, and Kenny Lamb.
Thank you.